Hello, I am Elizabeth Lee-Lewandrowski. I'm on staff at the Department of Pathology, Division of Clinical Laboratory and Molecular Medicine at the Massachusetts General Hospital. I also have faculty appointment at the Harvard Medical School. This education module is topic that laboratory blood-based testing for tick-borne infection other than Lyme disease at a national reference laboratory, a 7-year experience. The data presented here are from Quest Diagnostics. The general background data on pathogens are from CDC website. I'd like to thank my collaborators. Jin Chen from Quest Diagnostics, John Branda, Jason Barron from Massachusetts General Hospital, Michael Schneider, Harvey Kaufman from Quest Diagnostics. The speaker has no conflict of interest to disclose. The education objectives here are as follows. 1, describe the most common non-Lyme tick-borne illnesses. 2, describe the relative frequency of non-Lyme tick-borne illnesses reported to the CDC. 3, understand the potential role of reference laboratory data to monitor tick-borne diseases. Lastly, increase awareness of the most appropriate laboratory tests. This slide shows CDC list of tick-borne diseases found in the United States. It includes bacteria, viruses, and parasites. This module will only present the pathogens in boldface, which are Babesiosis, Anaplasmosis, Ehrlichiosis, Rocky Mountain spotted fever, Tularemia, Tick-Borne relapsing fever, and lastly, Colorado tick fever. This table shows tick-borne illnesses reported to the CDC from 2004 to 2016. There are 2 points here. 1, you see that where the arrow points is shown Lyme disease dominates all other tick-borne illnesses. 2nd point, all except the tularemia appear increasing all the other pathogens from 2004 to 2016. This table shows total Lyme test volume and number of positive tests by year from Quest Diagnostics. In 2016, there are 26,000 confirmed cases and 10,000 probable cases are reported to the CDC. However, a study by Hinckley et al. From 2014, using 2008 data from 7 large commercial reference laboratories, showed an estimated incidence of 244 to 444,000 cases. This indicates a significant underreporting to the CDCs. The data from this table from Quest also support the Hinckley study. It shows Lyme disease has increased from 2010, the 81,000 positive test volume to 2016, 100,000 cases. And compare with in 2016, there were only 26,000 confirmed cases are reported to the CDC. So this shows that Lyme disease is increasing and it is significantly underreported. Therefore, monitoring national reference labs may be more reliable data on the incidence and trends in tick-borne illnesses. First pathogen we're discussing here is Babesiosis. It is a parasite that infects red blood cell, usually caused by Babesia microti, transmitted by the black-legged tick, seen mostly in Northeast and Upper Midwest. Transfusion-associated cases have occurred. Infection can be from asymptomatic to life-threatening, especially in patients with asplenia or immunocompromised. Clinical findings: fever, malaise, fatigue, muscle joint aches, headaches, gastrointestinal symptoms, dark urine, mild splenomegaly, mild hepatomegaly, or jaundice may occur in some patients. Diagnosis: a demonstration of a Babesia organism in red blood cell on peripheral blood smear, as in this photo. Thick and thin smear are the best test. A positive PCR indicates active infection. The role of a serology, IgM and IgG, may provide a supportive evidence. However, it cannot differentiate current from past infection. This table shows Babesiosis PCR test volume and the number of positive tests at the Quest from 2010 to 2016. Of note, it increased both positive cases and increased test volume. In 2010, there's 109 positive cases. By 2016, there are 270 positive cases. The test volume in 2010 were 2,700. By 2016, it's 11,500. It's greatly increased test volume and the positive cases. This table shows the serology test volume and positive tests from Quest Diagnostics from 2010 to 2016. Note the increase in test volume and increase in positive tests. The serology test volume greatly exceeds the PCR volume. So here the serology has, IgG has a 393,000, IgM has 392,000. Where the PCR from the prior slides, you can see the volume was only 7 years, was 44,000. Although the PCR and the thick thin smears are more effective tests. This slide shows the Babesiosis positive serology test by state. Note mainly in New York, New England, and Upper Midwest. This slide shows the positive Babesiosis serology test by month of the year. Positive test peaks in the summer months, June, July, and August. However, it is observed through the year, all 12 months. The next pathogen we're discussing here is Anaplasmosis, formerly known as human granulocytic Ehrlichiosis. It is caused by Anaplasma organism. Severe illness is less common than other rickettsial disease. Most common in Upper Midwest and Northeast, Clinical findings: fever, headache, fatigue, muscle aches, GI symptoms, and rash in less than 10%. Laboratory findings: mild anemia, thrombocytopenia, leukopenia, elevated transaminases, visualization of moruli in granulocytes. Here you see the moruli in a cell, though it's not very sensitive. Laboratory diagnosis: PCR of whole blood is preferred. Serology: a fourfold rise in IgG antibody. IgM antibody is less reliable according to CDC website. This slide shows Anaplasmosis PCR test volume and positive tests from Quest Diagnostics. You can see the increased case detected. 2010 are 50 cases. 2016 are 244 five-fold increase. Where the total test volume in 2010 is 600. In 2016, close to 5,000. That's 8-fold increase. Though the volume, total volume is only 19,000. Even though it is more effective test methods than the serology. This slide shows the serology test volume and positive tests from Quest Diagnostic data. The total volume of IgM and IgG in 2010 to 31,000. By 2016, it's twofold increase. The positive test result in 2010 is 2,000. And by 2016, it's 3,500, but 2013 is 4,000. Therefore, the positive rate, positive test number or variables is now trending. And here you can see there are nearly 350,000 serology tests being ordered, whereas PCR was only about 19,000. This slide shows the positive serology test by states. It is mainly in New York, New England, and Upper Midwest. This slide shows the positive serology test by month. Of note, summer are the high peak seasons, so June, July, August, although it is observed through the years, both IgG and IgM. The next pathogen we're discussing here is Ehrlichiosis. There are 3 pathogens of known. First one is Ehrlichiosis. It's the most common and can be fatal. And no deaths has reported from the other 2 pathogens. Most are common in southeastern and south central United States. Correspond with the distribution of long-star ticks. Clinical findings: fever, headache, malaise, muscle pain, GI symptoms, altered mental status, rash. General laboratory findings: thrombocytopenia, leukopenia, elevations in hepatic transaminases. Moruli can be detected in about 20% of the patient. Here's a moruli in the cell. Laboratory diagnosis: PCR, first line, a documentation of a fourfold change in IgG specific antibody titer by IFA. This table shows the Ehrlichiosis PCR test volume and the number of positive tests. The test volume has increased. 2010 is 2,300. 2016 is close to 5,500. That's 2.5-fold increase. And the test positive result, though, is not trending. It's a variables. This table shows the serology test volume and the number of positive tests. The increased testing positive result is a variable here. You can see 2,000 in 2010, and then still 2,000-ish in 2016, although the test volume has greatly increased. Both IgG and IgM total, 2010 is close to 50,000, 2016 is close to 85,000. Here again, the serology total in 7 years, it's close to 500,000 tests. So it is exceeding the PCR test, which is only about 26,000 tests. It's shown in the last slides. This table shows positive Ehrlichiosis serology tests by months of the year. Summer months are the peak season. You can see June, July, and August. However, positive results are observed through the year. Next pathogen, Rocky Mountain spotted fever. It's usually transmitted by American dog ticks or Rocky Mountain wood ticks or brown dog ticks. Signs and symptoms. In early stage, high fever, headache, fatigue, muscle aches, edema around the eyes and on the back of the hands. GI symptoms, rash, but it's not always present. Here is the back of the hand and some rashes, a lot of rashes. Later stage, 5 days and beyond, altered mental status, coma, cerebral edema, respiratory failure, tissue necrosis, multi-organ system damage. Untreated Rocky Mountain spotted fever can be rapidly fatal. General laboratory findings, thrombocytopenia, elevated transaminases, hyponatremia. Laboratory diagnosis, PCR in an acute phase, use whole blood specimen. A 4-fold rise in IgG in the pair serum samples at the baseline and 2 to 4 weeks later. IgM antibody are less specific according to CDC website. This table shows the serology test, the number of positive results from 2010 to 2016. Again, it's not trending. It's the positive results. Both IgG and IgM are variables. This table shows positive serology tests by state. Rocky Mountain is somewhat a misnomer, considering where it is mostly often diagnosed. These states here, none of them are in the Rocky Mountain region. Positive serology tests by month. Again, here you see the seasonalities. In June, July, and August has the highest number. However, positive test results are observed through the year. Tularemia is this next pathogen. General signs and symptoms: fever, headache, fatigue, GI symptoms, muscle aches, cough, sore throat, and cutaneous ulcer at the size of bite. Here you see in this photo. Diagnosis: culture of the organism, fourfold or greater change in antibody titer. PCR, direct immunofluorescence assays. Positive serology tests by year, 2010 to 2016. So the numbers are, again, here's variables, varies, it doesn't trend. There's a small increasing, 2010 is 500 case. In 2016, 1,800 case. I suppose it is trending somewhat upward, but a small number. Positive serology tests by state. Here you have, again, upper Midwest and some New England state, some other state. The numbers are not huge. Next pathogen, tick-borne relapsing fever, Borrelia hermsii, Borrelia tularemia. Most common in 14 Western states. Symptoms: recurring febrile episodes, headaches, muscle and joint pain, chills, GI symptoms, arthralgia, facial palsy. Laboratory diagnosis: detect organisms in blood by microscopy. Here you see in this photo, the squeaky here, those are Borrelia bacteria. Culture during active febrile episode and serology. Common laboratory findings: normal to increased white blood cell, mildly increased serum bilirubin, thrombocytopenia, elevated ESR. Positive serological test results by year. 2010 had 222 cases, 2016 has 303 cases. Here you see the numbers are not trending any higher, so it's variables. The last pathogen here is Colorado tick fever, which is a virus, mainly found in Western United States. Clinical findings: fever, chills, headache, myalgia, and lethargy. Red eyes, pharyngeal erythema, lymphadenopathy. Rash in less than 20% of patients. Prolonged convalescence characterized by weakness and fatigue is common in adult. Laboratory findings: leukopenia, thrombocytopenia. Laboratory diagnosis: culture and PCR during the first 2 weeks of illness, and serology. This table shows the positive serological result by year. The number from 2010 is 444 cases, and 2016 is 1 case. See, the numbers are small, and the cases are positive result. IgG and IgM are small number. They don't seem trending any higher. Conclusion of this education module. 1, many non-tick-borne illnesses are increasing. 2, underreporting to the CDC is a significant problem. 3, data from national reference laboratories is useful to supplement CDC data. 4, tests have a variable performance depending on the timing, the organisms, the stage of the disease, and other factors. Thank you.